Okay, for the rest of the convex and concave chart, as far as where it asks you what is the what's moved, what portion is rolling and which portion is sliding, that's what I want y'all to answer and turn in for next week. So what I'm going to do is I'm not going to make another submission link. I'm just going to allow y'all, I'm going to go back into that submission link for when y'all turned in that chart, and I'm going to change it to allow you to put in multiple submissions, so that now you can go back in and finish the chart by next week and then submit it again, and then you'll submit the final chart by next week. Okay, y'all okay with that? Okay, now, and I'm giving you another week because what I want you to do is I really want you, as you're doing this, I promise you the pattern, the objects that Mrs. King drew out for you to cut out and use, she labeled them just the way you need to label them with a Sharpie. It will take you 5 minutes to cut this out and put the label on it. Do it. You will be so thankful. Any kind of paper will do. Just got to cut it out of paper. As you're making your chart, filling out your chart and thinking about the bone surfaces, use that tool that she gives you to answer the questions. Okay. That will be due by class next week, and I'll make the due date next Wednesday by midnight. Now there's going to be another homework assignment, but we'll talk about that at the end of this. Okay. But by next week, y'all's assignment now for convex and concave is to finish the chart. Okay. By next week. And then as soon as I get everybody's finished, I'll put up a key. And remember, as far as the other half of the chapter 4 homework, as soon as I get the homework turned in from that last person, if it's today, hopefully, then I will, I'll post the key as soon as I get it. Okay, so today let's move on. We're going to be talking about a different topic today. We're going to be talking about muscles. The muscular system. So it's already recording. Let me show you just a real quick. Let me show you a picture of what it looks like, the pattern you're going to cut out. Let me not share that. You don't want to see my mail. Let me bring it up.
Mr. Al, I have a question.
Yes.
I was trying to look for the recorded lectures. I feel like I can't find them anywhere. Are they under course content, or?
I think I've been uploading them to YouTube and then not putting them online. So that's my fault. So I'm glad you called me out on that. You emailed me that I saw it this morning and I was looking for it. So I'm going to fix that. So I'm sorry about that, Valerie.
Okay.
Thank you. I can always count on you to call me out on everything. You were going to keep me up to par on this program. Okay, this is a picture. Can y'all see this picture, the blue and red cutouts? Okay, this is the picture that I have online on Blackboard, and you can just print this out as a PDF. It doesn't even have to be in color, but cut it out and label it just like this. And this will be what I want you to practice and use as you're filling out your chart. Okay, and if you still have trouble with this, remember to watch Mrs. King's video that she made using these. She explains it very, very clearly, and do your best. And then if you still have a little trouble before next week, please email me, and we can set up a Zoom time, or we can do it through email, but I'm happy to meet with anybody through Zoom on any day. So we can do that. Okay, let's finally get on to the muscular system. Chapter 5. Okay. So everybody by this point knows y'all are buried up to your eyeballs in origins and insertions. Every muscle has an origin and an insertion. So every muscle has an origin, basically the part of the more stable end of the muscle, and it's got a more bony and it's attached to a bone by a ligament. And then you've got the insertion, which is the other end of the muscle, and it's the more movable end of the muscle, and it's attached, and it has a bony attachment there by a ligament. So everybody knows that every muscle has an origin and insertion. And by this point, I'm pretty sure I don't know exactly where y'all are right now in origin and insertions. I know that Mrs. King splits it up into sections, but some muscles have more than one insertion. So I don't know if y'all have learned that yet or not. Some muscles have 2 or 3 insertions. But if you haven't learned that yet, and I've just blown your mind, then pretend that I didn't say that. Okay, so here's an example of one of the bicep muscles, biceps brachii. So we've got one end of the muscle attached to the head of the humerus, or running through the head of the humerus, running through the bicipital groove, not through it, but on top of it. And then the insertion is inserting on the proximal radius on the other side of the elbow. So muscles need to cross a joint in order to in order to make movement. Because if they didn't cross a joint, then what's the purpose? They're just pulling on the same bone. Nothing would happen. Well, normally, all the time, and I should say normally, that when we move and in everyday movements, when we do muscle contractions, the insertion is moving towards the origin. Okay, so think about this picture of this guy. He's picking a cup up from a table or a glass of water to bring up to his mouth to drink. And he's doing that, mainly with his biceps. Well, as he's bending his elbow, those bicep fibers are shortening. And if y'all talked about the actin and the myosin filaments and all that right now, they're all coming together and zipping together. The muscle is shortening and coming together, and the insertion is moving closer toward the origin. Okay. And that's the normal direction of muscle contraction. Now, one example of reversal of muscle contraction is when the origin moves toward the insertion. Okay. Now, there's not going to be many examples of this. One example of this would be like if you were doing a pull-up on a pull-up bar, and let's use the same muscle again, the biceps. In this case, the biceps are the distal end. The insertion is fixed on the radius. That radius is not moving, but it's the humerus in the body that's coming up over the bar. So in this case, it's the origin moving toward the insertion. Now, this is very rare that this happens, okay? Okay, now, just remember those two things. Now, these are some categories of muscles, and we're going to go through all of these one by one. And I'll let you know which are the most important ones you need to know. Okay. So let's talk about muscle fiber arrangement. So in parallel muscles or oblique muscles, well, let's talk about this. Fibers are either going to be parallel to the muscle's axis, like going in one direction like this, or they're going to be oblique. And oblique, when we talk about an oblique line in geometry, an oblique line or in the body means it's going like at a diagonal, but it's still going in a straight line. Okay, so some muscles we have some muscles that the fibers are up and down like this, and we have some fibers where the fibers are oblique. Some of the best examples of oblique are internal and external obliques. Those are some of our abdominal muscles, and you can see those muscles on very easily on a muscle diagram. If you find the rectus abdominis in the middle, just look to the sides on the trunk and you'll see the obliques, and you'll see them coming down in a diagonal fashion down and inserting down on the pubic bone. Okay. Well, we have many types of parallel muscles. We'll go over some shapes of those in a minute. And we have a few different types of oblique muscles. And then we have a couple of other kind of have their own muscles that are kind of in their own category, spiral and circular. And I'll show you examples of those in a minute. So let's look at a picture of all of these. Okay, so let's look. These are the top row are parallel muscles, and the bottom row is oblique muscles. Okay, so a strap muscle is just a muscle that has all the fibers are going in one direction, and it looks like the belly of the muscle is about the same width as the tendons on the origin and the insertion side. Okay, so think of those as being like a lot of the muscles along your spine, your paraspinals, the very, very short, very small muscles that are spinal extensors and are postural muscles. Those are more tiny strap muscles. There are many, many, many of them put together, and they're very, very, they make a lot of strength for us. They keep our body upright all day, our trunk. Then you have fusiform parallel muscles. These are muscles that have one origin and one insertion on each side. And then the muscle belly is pretty kind of wide in the middle. Now, if you think about that, that could be like a lot of muscles in the body. Think about like your bicep muscles, your tricep muscles. If you're trying to tighten your muscles and trying to show off how big you are in the mirror and take a selfie, you're showing your biceps and triceps. Those are your fusiform muscles. Or you might be flexing your leg muscles. Most of those are fusiform muscles. Your rhomboidal muscles, the best example and one of the few examples of rhomboidal muscles in the body are the rhomboid muscles in between the scapula. And I guess those actually do go in a diagonal fashion. So but don't get them confused with oblique muscles, because all the fibers are running in the same line as the insertion and origin tendon. Okay. And then you have triangular muscles that have maybe a wide origin and then one insertion. And if you think about your deltoid muscles, there's an anterior deltoid, a middle deltoid, and a posterior section of the deltoid. It covers your whole shoulder, but all those fibers converge together into the bicipital groove. The deltoid tuberosity. I don't know why I got bicipital groove. The deltoid tuberosity on the side of the humerus, they all attach right there into this central tendon. So that's a parallel muscle too. Now let's look at oblique muscles. So you have unipinnate muscles, bipinnate muscles, and multipinnate muscles. So let's give you the best examples of each of these. Multipinnate muscles, let's look at those. look at all of these muscles, and I think, I mean, hopefully I'm not going to confuse you with this, but I think they look like feathers, at least the way these examples are drawn. If I'm confusing anybody with saying they look like feathers, I'm sorry, but it looks like a central vein, which is ligamentous, and all the muscle fibers are coming off of it in oblique directions. Well, if you've learned in origin and insertions yet, your OAINs, that if you're in the lower extremities yet, you'll know that the gastroc muscle, the gastrocnemius, each gastroc muscle has two separate heads. That's why if you look in the mirror and you stand up and you flex your gastrocs, you stand on your toes, or if you're a girl and you wear high heels a lot, or a guy that wears high heels a lot, then you'll see that people that wear high heels a lot or work their calves a lot have very prominent gastrocs. Well, you can usually see when they flex them on purpose that there's two separate heads of the gastroc. There's a lateral head and a medial head. And you can almost see where the tendon, you can see the central Achilles tendon almost separate, and then where the muscles separate and go off on their own. But at the top, they look like one big muscle belly, but down toward the mid part of the calf, you can see where they're a little separate. So it's a little tricky. You have to kind of know where you're looking. But that's an example of a multi-pinnate muscle. It's two separate muscle heads, but they have one central insertion, ligamentous insertion. I mean, a tendinous insertion, I'm sorry. Then you have a bipinnate muscle. And then unipinnate muscle, I'll give you the best example of that would be like your internal and your external obliques. They start off into a central ligamentous, tendinous junction that's attached to the insertion, and then the fibers spread out into an oblique fashion. So you can think of like your internal and external obliques being like that. And the fibers just go one direction from the origin. So let's look for real life examples. Okay. So there's some other ways to think about them. Let's look, here's some, well, actually here, I'm sorry, they're correcting me. I correct myself, I'm sorry. They're saying here that the deltoid, I said it was a strap muscle. It's actually a multi-pinnate muscle like the gastrocs. I'm sorry about that. And you can see because it's different heads converging into one tendon. But then we have other kind of muscles. We have long muscles, like the sartorius and the rectus abdominis. The rectus femoris is a long muscle. A convergent muscle. Here's a unipinnate muscle. Flexor pollicis longus of the thumb. Rectus femoris is bipinnate, even though it's also a long muscle, because it runs a very long, it's called a long muscle because it runs a long length, but it's also bipinnate too. Then you have a fusiform muscle, which is just kind of a little S shape. You have spiral muscles. And the best example of spiral muscle is your lats, because if you think about your lats, they originate from this thick layer of fascia and tendon around your spine, and they go up around your back of your trunk, and then they spiral up under your armpit and then attach to the lesser tubercle of your humerus. So we call it a spiral muscle because it turns and twists and spirals up under your armpit. So that's the way I remember it. And then you've got circular muscles. So we have the orbicularis oris, and does anybody know where this is?
It's around the eye socket.
Mm-hmm. And does anybody remember the one around the lips? Anybody remember the one that closes our lips? Makes us pucker? Well, I'll make you look it up because I can't remember it right now anyway, to be honest. Haha. Okay. Anyway, so any questions about muscle shapes? Hopefully I didn't confuse you on these. As far as knowing shapes and stuff, I just want you to know what a triangular muscle looks like. I want you to know the difference really between long muscles and multi-pinnate muscles and spiral muscles and circular muscles. Just the major shapes. These things, like, I don't care that you know the difference between a regular strap muscle and a fusiform muscle and a rhomboidal muscle. Now, if it is good to know it as you're studying it, but I'm not going to specifically ask you on a test what shape of parallel muscle is the biceps brachii. I'm not going to ask you that. But if you do need to study this to understand it better, then I would encourage you to do that. Okay. So I think y'all might have went through muscle physiology and A&P already. I'm pretty sure y'all did about contractibility. But every muscle in the body has a normal resting length when it's being unstimulated. Now, don't take that word unstimulated as meaning that it has no action potential going to it. Actually, even at rest, and even when we're asleep and unconscious. Now, unconscious sleeping is different than unconscious coma. When we're sleeping and normally supposed to be unconscious, even then our muscles have a little bit of stimulation going to them. And that would it's still a little bit of electrical activity going to our muscles. And that's what keeps our muscle tone. And that's what we call our muscle tone. And that's what gives us our normal resting length, okay? So even when we're still gonna say, a lot of times I'll say like a muscle, how long is a muscle, or what's the normal resting length, and you'll say when the muscle's being unstimulated. But just know that truly, that if you want to get down to the true nitty gritty of it all, every muscle is always has some electrical activity going, some action potential going to it. If it doesn't, then it's what we call a hypotonic muscle, low tone. And that's usually a pathological sign. Irritability of a muscle just means that it responds to a stimulus. It could be responding to pain or to cold or to touch, more like a reflexive contraction. Contractibility of a muscle just explains its shortening. So whenever we contract a muscle concentrically, we're shortening the muscle belly. The fibers are coming together. The extensibility is how flexible or how long we can stretch out the muscle at its longest length. So the extensibility of a muscle is how long it is at its longest length when it's stretched out. And all muscles have a certain amount of elasticity to them. So if you stretched out any muscle in the body and then let it go, and if you told the person to passively let you stretch them and to relax and then be still and then you let them go, there's going to be some elastic recoil there. I'm not meaning it's going to go all the way back to normal resting position, but there'll be a little bit of elastic recoil into the range of motion. Okay. Now we're going to talk, let's talk real quick about the length tension relationship in the muscle. And let me look at the next. Yes. Okay. That goes along with the next slide. Okay. So passive. So we know that our muscles are made for tension. Whenever we feel tension in our body, it's in our muscles. Nothing can keep tension except our muscles. And our muscles can cause tension, or we can hold tension in our muscles, okay? So we can have passive tension when we're stretching. And if somebody is if I had a biceps contracture and you're stretching my elbow out into extension, then you're stretching my bicep muscle and the tendon out, and you're stretching them to their longest length. That tension that you feel at the end range that you're stretching against, that's the passive tension of the muscle. Okay, that's the passive tension of the muscle. Active tension on a muscle is the tension that a muscle makes when it's contracting. Okay, and tone is that tension, that slight, that weak action potential that we have going on at all times, at all muscles of our body. So even like I'm talking every muscle, you name it, our abs, our quads, our glutes, our back extensors, our facial muscles, our pecs, our shoulder muscles, every muscle in the body, even our little bitty teeny tiny back extensors that y'all don't even know about yet, because you haven't got the thorax yet. There's more muscles that y'all, if you think you've learned them all this semester, there's more that we haven't told you about. Oh no, there's more. There's still slight action potentials going to those too. So there's slightly muscle tone in those muscles too. Now, let's go back to active tension for a second. This says active tension when contracting. Now, there's active tension, obviously, if I'm lifting a dumbbell with my hands and I'm doing a bicep curl, that's active tension because I'm shortening my biceps. And I think you can all see that. I think you all understand that. Well, what if I'm slowly, eccentrically lowering the contraction? Most people, when they do their bicep curls, are gonna, if they're doing it the way most people do, are just gonna drop them. But if you're doing it the right way, you're gonna lower it slowly, eccentrically. Now, my question to you is what is that? Is eccentric contracting, is that still active tension, or is that passive tension on the muscle? Somebody take a guess.
Active.
Active.
It's still active. It can't be passive, because passive is when we're putting you on a stretch. An eccentric contraction, even though the muscle is lengthening and going back toward its resting position, we still have to physiologically control that. So we have to do that, and we have to control that tension. So yes, very good. An eccentric contraction is still active tension. And on another note, an isometric contraction, say that you worked in acute care and you had a patient that had a hip replacement at 9 a.m. this morning, and now it's 3 p.m. in the afternoon, and the PT just finished their eval and they want you to go in and start exercising. And you don't think that that's early. That usually is about how you start on the same day of surgery when they're still waking up. Now, you're not going to do much stuff because they're still going to be coming out of anesthesia, but you're going to do simple things like isometric exercises in the bed, like glute sets and quad sets and ankle pumps, and trying to do just arm exercises above head, just to keep themselves active and moving before they get out of bed, and to keep themselves from getting blood clots and things like that. Well, even if you're just performing glute sets and quad sets, and tightening your muscles and then relaxing them isometrically, that's still active tension too, because even though the muscle is contracting and there's no joint movement, there's still some actin and myosin filaments coming together. So that's still some active tension. So all voluntary muscle contractions, isometric, concentric, and isometric, eccentric, and concentric are active tension. Okay. Now let's talk about so let's look at this picture here. I don't want this to confuse you. I'm not going to read through this whole slide everywhere. This would be a normal, every muscle has a normal resting length, and that's just the length of a muscle when we're at rest. So when you're sitting down in a chair, when you're sitting at your desk, when you're sitting at a table, when you're sitting on the couch, when you're laying on the bed, that's the normal resting length of a muscle, just when you're relaxed and not doing anything. And just for an example, on this picture, it says normal resting length is 6 inches. And that's just for that doesn't mean anything. Don't memorize that number. That's going to be different for every single muscle on every single person. So because everybody's a different size. So we're not naming any specific muscle here. But look what happens for muscle excursion. When muscle contracts, now it goes, this muscle in this example, the actin and myosin filaments come together, the muscle shortens, and now it's only 3 inches long. So that was its excursion. Well, I'm not going to say that yet. So it went from 6 inches from resting to 3 inches of contracted. Well, now let's look at this. So this is 6 inches stretch, 6 inches resting. Now look at when we stretch, if you passively stretch the muscle out, you can get it to 9 inches. Well, the muscle, what we call muscle excursion, is the distance between the muscle max contraction and shortening all the way to the muscle max elongation or stretch. Okay, so it would be 9 minus 3, which is 6. It's not always, and that just happens to be the same number as the normal resting length. That's not always going to be the case. But for this example, we just did that. Usually it's enough this is enough. Joint excursion for one muscle is enough to move a one joint muscle through its range of motion. Sometimes in 2 muscles that cross 2 joints, you'll have a much longer excursion than just this example. Okay, let's talk about length tension relationship here. And let's talk about the length tension relationship of the hamstring muscles. So the hamstring muscles we know are 2 joint muscles. So they start on the ischial tuberosity, that's where they originate, and then they cross the knee joint. So they're a 2 joint muscle. They cross the hip and the knee. Very complicated joint. So let's look at this example. Look at picture A. When this man, let's say this man puts his foot up on a step and then just stands there and he doesn't move. He just balances there with one foot up on the step and one foot on the ground. Well, can you see and visualize with your mind's eye that the fibers of the hamstring are elongated around his hip joint because he's stretching them. He's flexing his hip joint up here, which is putting those fibers on stretch. But down at the knee, he's shortening those fibers because he's flexing the knee and shortening that distance. So can y'all see that in the length tension relationship, that in sometimes we can have in the same muscles, we can have elongation at one end and shortening at the other end. Can y'all see that, or does that confuse anybody? So let me explain it a different way. So think of the hamstrings as just being a long rubber, and there's three, and you got three of them. So they're just rubber bands. Think of them as being rubber bands. Well, one end attaches to the tibial tuberosity, and then the other end's attached to the tibia, the top of the tibia, posterior tibia. Well, when this man's leg is put on top of the step, the rubber band up here at this end is stretched, but down at this end, because the knee is flexed, because the knee is flexed, it's now shortened, and this end of the rubber band is on slack. Okay, does that confuse anybody, or can somebody, y'all, a few people let me know yes or no that y'all can see that? I can't see anybody, so can I hear a yes or no? Yes.
Yes.
Okay.
It's more obvious in the book.
Yes.
Looking at the book pictures.
Okay. Well, that's why you have a textbook, because the teachers aren't always perfect. Now, look at B. Now, he stepped all the way up on the step. Now, it's opposite. The hamstring fibers behind the knee are more elongated versus down here when they're shortened. And these hamstring fibers are more shortened compared to these, which are lengthened over the hip. Okay, now a step up in this example right here is a very good example of how to study length tension relationship of two joint muscles. So if a two joint muscle, if this is too confusing for you, hold on, go back to this slide and think about lengthening and shortening of one joint muscles, and we'll say that this slide is of a one joint muscle, and then look at this slide again and try to think about it. But but like Jackie said, it does explain it in the book, and let me just say, don't ever take my word and PowerPoints for everything. Yeah, they have other pictures that I can't fit on every single slide. And they say it in a different language than me. So, and they may say it in different terms, which you may understand. Some people may get differently. So, and that's not just for my class, that's for every class. So I always encourage you to read the book. And I know that sometimes you don't always want to read chapters that are long, but especially some classes are longer than others, but it's just to your advantage. So, okay, so let's move on. Okay, so now that we talked about that link tension relationship, ooh, we need to hurry. We need to talk about active and passive insufficiency. Okay, so look at this picture of a man standing on one leg, and he's standing on one leg. So he's flexing his knee in the air, okay, and holding it there isometrically. So anybody, name it. What muscle is holding his leg there in the air?
Hamstring.
His hamstrings, okay. Oh, that was a simple answer. Okay, his hamstrings are doing that. So that is a lot of active tension, yes. Can you see how that's active tension? Yes or no?
Yes.
It's active tension because he's actively flexing. Okay, now there's a certain point in everybody's muscle that we can't contract any further because the actin and myosin filaments basically zip each other all the way that they can, and that's as far as we can actively do it. It has nothing to do with our strength or our muscle bulk or our infield. It's just that that's all our hamstring can do. Well, look at the second picture here. Look at how much further he's able to bend his knee with his hand. Can you see that actively he can only bend to about 90 degrees at his maximal ability against gravity? But with his hand, he can pull it even further into flexion if he pulls with his arm. Can y'all see that? Okay. This picture right here of A is called active insufficiency. It's the point at which a muscle cannot shorten physiologically any further. It's the point in which the patient or you can no longer sufficiently contract your muscle. Every muscle has a point of active insufficiency. Okay. And you always know if there's active insufficiency if the patient or if you as the therapist can push that joint into further range than the patient could. If you can, then you know that they had some active insufficiency going on. And maybe you could stretch them and get them, and maybe what you could do, and then that lets us know maybe it's a strength thing, maybe it's a muscle thing, maybe maybe that's just all that they have, or maybe their quads are tight right here in the front and not letting them bend anymore. So before we use that example, let's use the quads as an example. Okay, so the quads are going to be the complete opposite of the hamstrings. So are the quads stretched or lengthened in this? I'm sorry, are the quads contracted or lengthened in this first picture? Somebody tell me.
Lengthened.
They are lengthened. Okay, so in this point, they're being put on stretch, right? Can you see how they're being put on stretch? Okay, hold that thought. We're going to the next picture. Now, look at picture B. Picture B represents the exact same thing. This person is trying to touch their toes by bending over with their knees straight. And they're elongating their hamstrings over their hips and their knees. Can you see that that's the maximum length that the hamstrings will let them go? We've all had, when we all touch the floor or try to touch our hamstrings, even if you're like most women and can touch your toes or have a good straight leg raise, you're going to feel a stretch in your hamstrings. I can barely touch my feet, my toes in standing, and my hamstrings are on fire. That is a very good example of passive insufficiency. That's the point in which a muscle cannot be elongated any further by either the patient themselves, they can't stretch it any further, or you as the therapist cannot stretch it any further. Okay, so let me see what the next one does. We're almost done here. Let's stop there for a second. So we've just hit two things. We were in resting, we were in different range lengths, resting length and elongated lengths. And now we're in active and passive insufficiency. Do y'all understand how active insufficiency works? It's the maximal point that a muscle can physiologically shorten on its own without external help from another. So in this case, this would be the active insufficiency of this patient would be picture A for his hamstrings. He can only flex to 90 degrees. That's as far as his hamstrings would shorten. But with his hand, or if you stretched him, you could stretch him into more knee flexion. And then for passive insufficiency, that's as far as you can lengthen. So active insufficiency is shortening. Passive insufficiency is lengthening without damage, so without tearing the tissue. So the best example of passive insufficiency is when you're doing any kind of stretch and you feel the tissue stretching. That's passive insufficiency of that muscle that you're stretching. And that's the position that you hold the muscle in to stretch it, is in the passively insufficient position. Does that make sense? Okay, seeing some nods, so I'll keep going. Okay, let me see what let me look through these real quick. Well, sorry. We're not gonna quite finish, but some of this y'all already know. Let me let you know what a tenodesis is, and then then the rest of it is pretty much review. A tenodesis, if you remember from medical terminology, teno means tendon and desis usually means fixation. Well, in this case, tenodesis is a trick that people do that don't have active wrist flexion, wrist or finger flexion. So spinal cord injury people that have the ability to, and if y'all can see my hand, if they have the ability to extend their wrist, that's usually that's something that C6 can control, that the C6 and C7 myotome can control. C8 controls finger flexors and finger and forearm flexors. Well, they'll get this way before they get this, if they're going to get it. So people that can do this can still learn to grasp things and they use passive insufficiency. So watch my hands. When I'm in full resting flexion, and this would be a patient in resting flexion, my fingers are extended and my wrist is flexed. So what they will do, they will put their hand on a table, and then they will arrange themselves around a cup, and I'm going to put my cup so y'all can see me. And then what they're going to do, they're going to extend. They're not going to grab. They can't grab onto the cup. They can't grasp the cup. but they're going to do the opposite of what we do. They're going to extend their wrist and as much as they can. Well, look what happens at rest when I extend my finger, when I extend my wrist. My fingers flex. Can y'all see that? I didn't flex my fingers actively. And if y'all do that, hold up your hand and do this. You can feel that you're not flexing your fingers actively. This is when you actively extend your wrist, you're taking up the slack of the flexor tendons and making them go into passive insufficiency. And then if you try to further extend the fingers, then you'll really feel a passive insufficiently stretch. So that's why in the spinal cord world, a lot of people, some people, we do want to stretch out their fingers so they don't get stuck like this, but most of them, we want to teach them to use that trick. But those are about the only people we teach that trick, that tenodesis trick to. That's just with spinal cord patients, because most of the neuro patients, we want to be able to teach them to do it the right way. Y'all know what concentric, eccentric, and isotonic is. And remember, isokinetic is with the special machine. The other ones are just a review, so I'll let you go over those slides. Remember, isokinetic is used more where it's done with a machine, and it measures the strength and speed of a person's joint range, usually in both directions, and it's used more for athletic purposes. I'm gonna have to, well, it's time for class to end, so I'm gonna have to stop here. We'll come back to this slide. Y'all, please finish up this lecture on your own, but we'll start here next week and try to finish this up, okay? But I'll go ahead and post this version of the recording. So, okay, guys, so y'all remember to, by next week, finish up that the chart. And remember, I'll put up a key for the other fill in the blank homework as soon as that last person turns it in. Sorry I went up to the last minute, but y'all are free to go to class or whatever y'all need to go now.